tissue at that stoma. Drawing blood from a central line, because we put heparin in, if nothing's running, or if something's running, the line is full of whatever solution is running. So you've got to draw out blood to clear out whatever's in that line, then draw out the blood that's going to lab. Then we replace the blood that we used, our waste, and I think in adults they don't always do that, but we do with kids. And then you want to flush it. You don't want to leave that tube full of blood and then either heparinize it or reconnect it. That is not something students are allowed to do, but if it's your nurse or your patient's having that done, watch, help. But you can't be the one to actually draw it out. That is a sterile procedure with opening all the packages sterilely and sterile gloves. This is where you poke for a Heelstick on an infant. You can see the little purple dots down on the heel. That's the best spot to poke. And here's a picture preparing some kids. At Children's they have lots of dolls that have PICC lines and Broviac lines and G-tubes and trachs and everything else, whatever the kid might be getting. So they can see it on a doll, they can play with it, they can touch it, and then they're not so scared of it suddenly being part of them. I believe this slide was on another chapter, but blood pressures on children, you do need to make sure the cuff is the right size, and that we usually will use that brachial artery just like an adult in the upper arm. You can also use the lower arm or the thigh or the calf, but you have to make sure the cuff is right and that you have the line for the artery over the artery that you're checking. And it's just showing on there, if you use too small of a cuff, you'll get a falsely high blood pressure, that's the middle one, and if you have too large, so that it's going all the way from the elbow up to the armpit, the axillary, you'll get a falsely low. And here's the other one showing the other spots you can take it. Brachial artery is the standard. You can do the lower arm where you're going over the radial artery, which is right by the thumb. You can do the upper leg where you're going to actually be over the popliteal, which is the back of the knee. And the calf, you're usually the post-tibial, which is right behind the medial ankle bone. Temperatures, they use a tympanic thermometer at Children's for a child over a year if they're not in isolation. If they're in isolation, they'll usually have a digital one in their room. But the tympanic, you've got to make sure you're shining the light onto the tympanic membrane, which means you've got to pull the ear back and angle that a little bit towards the nose so that you're pointing towards the tympanic membrane. For kids over, I think it's 6, they can use an oral one, and infants under a year, typically they're going to do axillary. And again, letting a child play with stuff, it makes it less scary, and then they're much more willing to let us use it on them if they've been able to touch it and play with it. You'll see lots of kids who are on a SAT monitor, and it has the light on one side and the photo detector on the other side. It's measuring how much oxygen's in the arterial blood as it pulses between those two. If you're not getting a good pulse waveform, if it's not accurate with their pulse, if the pulse is not accurate, the O2 sat is not accurate. Don't use the pulse as your only measure of their pulse rate. The pulse is on there to ensure that it's accurate. So check their pulse. If you're getting very close to the number it says, then you can trust that the O2 sat is accurate as well. Don't overuse, or I often hear people using the O2 sat by itself as being of greater importance than it is. It's an important measure, but it tells us how much of all the hemoglobin groups, how many of them are carrying oxygen in the arterial blood. It doesn't tell us that we have enough hemoglobin groups. You can be 100% saturated, but still not bringing enough oxygen because you just don't have enough of those hemoglobin groups. Or you're not perfusing well. This is down on the toe. If you're perfusing to the toe, you're probably perfusing the rest of the body very well. But it doesn't tell you that there's enough hemoglobin groups, and it doesn't tell you how well they're moving. It just tells you how much they're carrying. So it's a good piece of data, but you really have to look at the labs as well to know that they have enough hemoglobin. Trachs, you're going to get to take care of kids with trachs. Most of the time we don't deep suction. We will occasionally, but most of the time these kids can cough it up right to the tip, and all you've got to do is suction a couple of centimeters. So you're not going down below the base of the trach. We do need to occasionally do it because we don't want to let a mucus plug form down there. But the more we go past the bottom of the trach tube, so that we're in the child's trachea, we stimulate more secretions, we have more trouble. So if the child's able to bring it up, we're going to just catch it from the tip of the trach tube and not go all the way down most of the time, and then just the occasional deep suctioning to make sure they're not developing any mucus plugs down deeper. And that's the last slide for this section.